Hello, my name is Dr. Pamela Kunz, and I'm the leader of the GI cancer program at Yale and also a neuroendocrine tumor researcher. Elise, thank you for the introduction. Today I'm going to talk about CAPTEM treatment. These are my disclosures. I'm going to start with some definitions. CAPTEM is an acronym that stands for 2 oral chemotherapies. The first is capecitabine, also known as Xeloda. It can cause side effects that can include diarrhea, skin dryness on the palms and soles, and mouth sores. Temozolomide, or Temodar, is the second of the 2 chemotherapies. It can cause side effects of fatigue, nausea and vomiting, and lowering of blood counts. Both are oral chemotherapies, and the dose is tailored to you. It's based on a combination of your height and your weight using a formula called the body surface area. So who should use CAPTEM? CAPTEM has primarily been studied in pancreatic neuroendocrine tumors. There is some data in lung neuroendocrine tumors and very little in GI neuroendocrine tumors. CAPTEM has the best chance of tumor shrinkage compared to all of the other treatments for pancreatic NETs. Therefore, it's used primarily in patients with large tumors, tumors causing symptoms, and tumors growing rapidly. So what is the evidence for using CAPTEM? This is based primarily on a randomized phase 2 study of temozolomide and capecitabine in patients with advanced pancreatic NETs. This was a large clinical trial run through the National Cancer Institute through a national clinical trial network called ECOG-ACRIN, and the clinical trial name was E2211. I had the opportunity of serving as the principal investigator of this study along with a large study group. So the study design for this clinical trial is shown here. I'll walk you through this briefly. Patients with progressive grade 1 and 2 metastatic pancreatic NETs were randomized 1-to-1. That means half got arm A and half got arm B. Arm A was temozolomide alone, and arm B was the combination of capecitabine with temozolomide. The primary endpoint, which meant the primary measure for defining success for this clinical trial, was progression-free survival. I'll walk you through this slide also. So the x-axis, or the horizontal axis, is months. The y-axis, or the vertical axis, is the progression-free survival probability. The dashed line in the middle is the median progression-free survival. And as you can see, the orange line of temozolomide and capecitabine had a median progression-free survival of 22.7 months versus 14.4 months for temozolomide alone. The separation of these curves is good. It means that that orange curve did better. And we measure that by looking at something called the hazard ratio. So low is good for both the hazard ratio and the p-value. That hazard ratio indicates that there is a 42% lower hazard or lower risk of progression with the combination arm of TEM plus CAPE. The overall survival curve has a similar look. It showed a similar pattern to the progression-free survival curves. In orange is the combination arm of temozolomide and capecitabine, and it did better, so a longer overall survival than for the temozolomide alone arm. That combination arm had not reached median overall survival at the time this was presented, but there is a statistically significant difference between those 2 arms. Response rate is a way that we define how much tumors shrink on a clinical trial. This is defined by RECIST criteria, which is an acronym that stands for Response Evaluation Criteria in Solid Tumors. The key features of RECIST are that we only measure a maximum of 5 lesions. We measure up to 2 lesions per organ. The sum of the longest diameters is compared over time, and a percent change is calculated. And that percent change is grouped into 4 categories: complete response, which means disappearance of all lesions; partial response, which is greater than or equal to less than 30% shrinkage; stable disease, which is between 20% and a negative 30%; and progressive disease, which is greater than or equal to 20% growth and or new lesions. This is a figure that just helps understand tumor measurements a little bit better. It's a cartoon of the liver. So the liver is in blue, 2 tumor lesions are in yellow, and this represents baseline or before treatment. So one lesion measures 6.5 centimeters and the other measures 2.5 centimeters, and we put that into a table. This is that same liver after 3 months of treatment. Those 2 lesions have shrunk, as seen in the table. And if you add up the longest diameters, that represents 17% shrinkage or stable disease. This third picture represents after 6 months of treatment. And we add those tumor measurements to the table. That then represents 44% shrinkage or partial response. So as this relates to ECOG 2211, both arms actually achieved fairly high response rates. So temozolomide alone had a 27.8% response, and temozolomide plus capecitabine had a 33.3% response. So about 1 in 3 patients on this study had an objective response. Adverse events are another very important endpoint for clinical trials. It's our way of assessing safety. They are collected and recorded by the research team. We look at severity on a scale of 1 to 5 and relatedness, whether or not it's related to the study drug. This is just an example of the common terminology criteria for adverse events and using anemia as an example. And as you can see here, there are grades 1 through 5, and that helps define the severity or level of anemia. So for ECOG 2211, we can see here that the combination arm of temozolomide plus capecitabine had higher rates of adverse events than compared to temozolomide alone. This is not surprising given that there's more chemotherapy. We had actually almost double the rate of high-grade adverse events, so grade 3 and 4. And these were primarily in the range of hematologic, so affecting neutrophils and white blood cells and lymphocytes and platelets, that's the thrombocytopenia, and also GI side effects, including nausea, vomiting, and diarrhea, and also fatigue. I want to also highlight that CAPTEM was reported at ASCO 2020. ASCO is our large oncology professional society meeting. The group from Moffitt, led by Dr. John Strasberg, and his colleague, Dr. Altuba, presented a study that was a retrospective single institution study of advanced neuroendocrine tumors who received CAPTEM. They looked at 462 patients, 210 women, 252 men with a median age of 59 years. The median duration on treatment was 8 months. And of note, the average starting dose was about 10% lower than target doses. 25% of patients required a dose reduction and 16% discontinued due to any toxicity. I'd like to highlight here some of the key take-homes from this study. So of the grade 4 hematologic adverse events, they were relatively low, but one thing that's reported in this study that has never really been reported before are the differences between men and women in terms of these adverse events. Women had higher rates of low platelets, low neutrophils, and low lymphocytes. And then other toxicities of interest and things I get asked quite a bit about are, does CAPTEM cause a higher rate of infections? There were very low rates, only 1 case of a fungal infection and 5 cases of shingles out of that 462 patients. And myelodysplastic syndrome, which is a form of bone cancer, there were 3 cases of myelodysplastic syndrome, all who had had prior PRRT. Some practical considerations just in terms of how CAPTEM is taken. Capecitabine is taken twice a day, daily on days 1 through 14. Temodar is taken once daily on days 10 through 14 and then 2 weeks off. So as an example, if we were to put this in a calendar of September 2020 with a start date of September 6th, you can see how that works here with days 1 through 9 being capecitabine alone and days 10 through 14, both medications are taken and then 2 weeks off. We also recommend that Zofran is taken to prevent nausea 30 minutes prior to Temodar. So take-home points, we've had many advances in the field of NETs over the last 10 years, both in terms of treatment and imaging. CAPTEM is better than TEM alone, as shown by this large clinical trial. It delays progression and can shrink tumors. And CAPTEM is now one of our many treatment options for pancreatic NETs. And the decision as to whether or not that's right for you is really a conversation for you to have with your medical oncologist. So I'd like to specifically give thanks to patients who have participated in clinical trials, and thank you for your time today.